Then let's get into face and neck. I need this guy. Yes, okay. Also, I am going to show a couple of fairly graphic pictures today. So if you're someone who's going to have issues with graphic, close your eyes, rethink some life choices, because this field is graphic. But I digress on that. I'll let you guys understand your own mistakes on your own volition. So, getting into the face and neck. Now, we're skipping soft tissue. Soft tissue primarily composes your face and your neck, okay? Has anyone ever gotten like a cut on their forehead and then they just notice it bleeds and bleeds and bleeds? That's essentially soft tissue. It's a lot of small vasculature that typically does not cause shock, but it can bleed, if not controlled, can bleed enough to cause shock. Does anyone remember what type of shock we're dealing with when it comes to bleeding? Huh, what? Not compensated. That's the one, hypovolemic. You keep getting compensated, decompensated. Those are stages of shock, not types of shock. Okay, so we can see hypovolemic shock start to show up here, right? Now this is also, once again, we're in trauma. This is going to be the introduction of understand the mechanism, okay? The mechanism of injury. Now remember, the mechanism can be so much deeper than just someone getting punched in the face, for example. Someone gets punched in the face, they got a black eye. Is there any implication potentially to their neck? Is there any implication potentially to their brain, right? We got to look past just the black eye. These tend to become the injuries or the issues that people, not people, how do I want to describe this? Providers will kind of overlook because they think, oh, they just got hit in the face, no big deal. There's a lot of stuff that lives behind your face, right? We got to make sure it's all looking good there. So the face and neck, vulnerable to injury and are relatively unprotected positions on our body, right? Obviously, it's hard to have an exposed face and see and smell and taste things if your face is always covered in bones, which none of yours are. Good to look. Now, soft tissue injuries and fractures are common and they can vary. And then some injuries are life-threatening, right? If we have penetrating trauma to the neck, it can cause severe bleeding. If we have an open injury in the extent of like our jugular veins or our carotid arteries have exposure to the outside world, we can get air into those arteries, or into those veins, vasculature if you want to summarize it, which an air embolus can cause quite a bit of problems, okay? We'll talk about blood clots when we get to medical. Typically, issues like heart attacks, strokes, PEs, pulmonary embolisms, those are more of a blood clot problem, but it doesn't have to be a clot. It can be anything that's not blood that entered our bloodstream. So air, amniotic fluid, adipose tissue, bone marrow, all of those are potential examples of things that can get into our blood and cause blockages, okay? So if we have an open vessel to air, we put ourselves at risk, okay? Now, some A&P. Also throughout the rest of these lectures, you'll notice we're going to do a little anatomy and physiology review just to kind of remind everyone what structures we're talking about. So, the head. First part is the cranium. The cranium is basically the skull cap, right? The rounded cap to your skull there. Contains the brain, with the most posterior portion of our cranium being called the occiput. Can someone tell me the name of the lobe that lives below the occiput? The occipital lobe, right? So putting two and two together there. Lateral portions on either side are called the temples. What lobes live below the temples? The temporal. Everyone seeing we're putting it together, right? One thing's going to kind of guide us towards the next. Forehead's the frontal region. I'm just going to say it because we're kind of putting pieces together. Frontal lobe below the frontal region. And then anterior to the ear, so in front of our ear, we actually have a pulse point, okay? The temporal region, we can feel our superficial temporal artery. So if you ever stress out and you feel like you can hear your pulse in your ears, that's what it is. Your blood pressure is going up because you're stressed and you can hear the artery that's running right in front of your ears, okay? Now, the face, what we're really getting into for this one. The face has 6 major bones, including the nasal bone, right? And if you feel your own nose, you can feel when it goes from bone to cartilage. We have our 2 zygomas. The zygomas are your cheekbones, and you can see some different variations of that. Zygoma, zygomatic arch was how I learned it, but it means cheekbone. That's what we're referring to, okay? You have your 2 maxilla, which your maxilla is fused. It's just a couple of bones fused together, but that's your top teeth, where your top teeth attach to your skeleton or your skull. That's your maxilla, and then our mandible, once again, is our chin. Okay? Should be a little bit of review. Any questions on this stuff so far? That's exactly what I was hoping was going to happen. So now we can get a little bit deeper into the eye. So the orbit of the eye. When we're talking about the orbit, we're talking about the surrounding bones of the eye. Okay? When I'm talking about the eyeball itself, I'm talking about the globe. Okay? The globe is in orbit. Okay? So the lower edge of our frontal bone is going to form the top part of the orbit. Okay? So it's going to form the top portion there, the superior portion of it. The zygoma is going to start forming these sides, right? That's what attaches to the frontal bone, our cheekbone here. And then we have our maxilla, which actually reaches up and forms the interior socket here. And then for the most medial, we have our nasal bone. Okay, so nasal bone, frontal bone, zygoma, maxilla. Okay, all circles in. Now there's a couple of other bones that actually make up the floor of your orbit. They're called the ethmoid and the sphenoid, but you don't need to know those for your guys' sake. Okay, but the orbit's job is to protect our eye from injury. Right? Our eyes are obviously very soft structures. We don't want to damage them, so we need to keep a rigid, bony protective layer over them. Okay, so only the proximal third of our nose is formed by bone, like I was kind of talking about. The rest of it's cartilage. Okay, now cartilage is a fairly durable and fairly rigid tissue type. You can still break it. It can still get mushed if there's enough trauma, which I'll talk about some of that maybe in a little bit. Now we're also going to start including the ear as part of this. Okay, so the exposed portion of the ear is composed entirely of cartilage covered in skin. Now there's a few portions of the ear you're going to need to know. One of them is that superficial temporal artery, right? The one that runs anterior on your ear. But there's a couple of other ones that you're just going to need to know. The first one is our pinna. The pinna is the round portion of your ear. Okay, the cartilaginous round portion of your ear. Okay, and then we have the tragus. Can someone show me or know where the tragus is on our ear? Yeah, the tragus is that little bumpy guy in the front. Okay, that's the thing that some people will say if you pierce it, it helps with migraines. That might be true. I don't really know. I can't confirm. Feels like a silly thing to me, but what do I know? Okay, so pinna is the round part of your ear. The tragus is that little bump in the front. Okay, we will talk a little bit deeper today about the ear's actual anatomy internally, but for right now, superficially, you do need to remember these, okay? Now, about 1 inch posterior to the external opening of the ear, right, so your ear hole, is the mastoid process. So if you feel behind your ear, you can feel the back corner of your skull. That's the mastoid process. That's an important site. I want you to highlight that, mark that. That is going to come up in our next lecture today. The mastoid process is going to provide us important signs. Okay? And then our mandible forms our jaw and our chin. Right? That's the hanging bone that attaches your lower teeth to your skull, right? Your mandible. Questions on any of this stuff? Now, we've talked about that, or I kind of mentioned it briefly, that sternocleidomastoid bone, or excuse me, muscle. And that's that big one in the front of your neck, attaches to your sternum, passes your clavicle, attaches to the mastoid, sternocleidomastoid. That's why it's named the way it is. A lot of anatomy is labeled and structured pretty sensically. You just got to pay attention to it. No questions? I'm going to move on. Okay. So the neck. Now our neck obviously also contains some pretty important structures. Okay, supported by our cervical spine. How many cervical vertebrae do we have?
7.
7. Good, good, good. 7 cervical vertebrae, right? So that's going to make up the neck. Does anyone remember what the name of the first vertebrae is? Brainstem. Not the brainstem. Not axis, atlas. Yeah, the atlas holds up the world, right? Now what's the name of the second vertebrae? Axis. Axis lets us turn, right? Turning on an axis. Second vertebrae, so C2 is our axis, C1 is our atlas. Very good. Now, part of that neck, right, if we're talking in the midline, we have our esophagus and we have our trachea. Our trachea is more anterior. That's what you can see on people's throat, right? That's their Adam's apple in males, or like where it is, right? But the windpipe. And then the esophagus lays a little bit deeper, more posterior compared to the trachea itself, and that's our food tube, okay? But both of those run in the midline. Now on either side of that midline, we have a couple of important structures, or a couple of sets of, I'll say, important vasculature. We have our carotid arteries and our jugular veins, okay? Now you actually have two jugular veins on either side, an internal and an external jugular vein. So when you see that big neck vein in people, that's an external jugular vein. We like to surmise that down to EJ, because we're lazy, an external jugular, even though it sounds fancy, is a long word to say when you don't have a lot of time. But that's when we'll actually get IVs in above your guys' scope. We'll get EJs. All right. So here's a kind of a view here. So also part of the throat, like I was saying, I did mention the Adam's apple. That's the larynx, right? The Adam's apple, in more particular, is the thyroid cartilage. That's what you're feeling. The thyroid cartilage, hint, hint, wink, wink, comes to a point. It's a V-shaped set of cartilage in everybody. It's just more prominent in males, okay? So the Adam's apple located in the center of the neck. The other portion of the larynx is the cricoid cartilage, which is the next big ring down. So if you find your Adam's apple and you feel down, the next big ring you feel is your cricoid cartilage, okay? That set of tissues is essentially your larynx, okay? And then another important section to remember if you're going to advance your scope is that cricothyroid membrane, which is that cric, okay? When we do a cricothyrotomy, when we have to put a tube in people's neck to breathe for them, that's the location we're looking for, okay? Questions on the larynx at all? Okay. So, like I said before, the cricothyroid membrane lies between the thyroid cartilage and the cricoid cartilage. So, cricothyroid membrane, right? Easy ways to put it together. But that's the one, like I said, we will cut. I'll show you that video when we get to airway down the way. Now, in the trachea, below the larynx, that's the extension of the trachea, right? So that's the cartilaginous rings. If you feel your Adam's apple cricoid and you keep feeling down, you feel those rings of your windpipe, okay, that's all cartilaginous. So, and that's going to be what connects the oropharynx and larynx to the main passages of the lungs. That's going to connect your lungs themselves to that open oropharynx, right? Remember the pharynxes are the spaces behind the nose, mouth, and then the throat there. Okay, and then we have, I mentioned it earlier, the sternocleidomastoid. Originates from the mastoid, past the clavicle, attaches to the sternum, and that's what allows us to turn our head. Okay, that big, big muscle there in the front. So it's an important one, right? Things you got to keep track of. I haven't typically seen like severe injury to that area, but I've heard people straining that muscle. As you get older, if you sleep with your head weird, that's usually the muscle that hurts. Some of you don't get it, but you will, trust me. And it doesn't feel awesome. Some of you can relate, unfortunately. Questions about the structures of the neck, structures of the face at all? Cool, moving on. So we're going to get into the eye. Now remember, orbit is the bones, globe is the eye. So it's a globe-shaped 1-inch diameter structure, your eyeball, approximately 1 inch, depending on the size of the person will dictate the size of the eyeball. And then there are some people, I'm sure you've seen them, who just have big eyes in comparison, okay? Now, they live in the bony socket called the orbit, and they're composed of adjacent bones of the face and skull, right? We talked about it. Frontal, zygoma, maxilla, nasal forms the exterior portion of our orbit, okay? With the orbit protecting about 80% of the eye. Kind of makes sense why we want to protect 80%, right? Why do we not want to protect 100% of our eyeball? Yeah, I can't see. You got to be able to look around, right? It's kind of a counterintuitive thing otherwise. Yeah. So here is the eyeball. I want to double check something. Yeah. I'm going to over-explain my images like I always do, and then we'll talk about it a little more. So looking at the eye, first things first, that lens that is directly over your pupil, I'll go into pupil, you know what that is though, is your cornea. Okay, so when you hear someone say they scratch their cornea, they scratch the lens at the very, very front, or the tissue at the very front of their eye. Okay, now Below the cornea, we have our pupil. What's the pupil? Or not pupil. Yeah, pupil. Well, I say pupil. What's the pupil? It's the hole, right? The hole in the middle of your eye that lets light in. What's the iris?
The colored part?
Yeah, the iris is the colored part of your eye. The iris is also a muscular portion of your eye, right? Because we want it to open and close depending on how much light we have around us. Okay, the brighter it is outside, the smaller our pupil gets because our iris contracts because we don't need that much light to see. Okay, inverse, when you walk through your house in the dark or outside in the dark, and your pupils are going to get really big because they're trying to gather any available light to help you see. Okay, now cornea, pupil, iris, with the iris kind of forming the pupil. The pupil is just a hollow space. Behind that we have the lens. Now the lens, everyone's shaped a little bit differently, and that's partially the reason that we will wear glasses, or some of us will wear glasses, okay? Just the shape of our lens. It also has to do with the shape of the actual eyeball, which is why a lot of older folks, anyone's parents wear the little cheater glasses, like the little reading glasses, you buy it like Walmart. That's because the eyeball, or the shape of their eyeball, is actually changing. That's why when you hand your dad your phone, you're like, hey, check out this meme, and he's like, ooh, you know, it's because he's got that change in eyeball shape. Okay? Now, moving more internally into the eye. First of all, we have the kind of the jelly, right? They call it semi-liquid, but it's a jelly-like substance. That's called vitreous humor. Vitreous humor. If you've ever seen Kill Bill, which is one of my favorite movies of all time, there's a scene where she steps on this gal's eyeball and you see the jelly come out, and it's very visceral, and you know exactly what that felt like. But what you're seeing is that vitreous humor. Yeah. Yeah. Okay. Pause. Yeah, keep going. Sorry about that. Okay. So, vitreous humor is going to be the jelly in the middle. Now, a lot of you have probably heard about the retina before, right? The retina is basically it's layers. There's layers to our eyeball, and the retina is the innermost layer, which is what basically allows us to see, or part of what allows us to see. Our body is built on surface area. Surface area is a very important concept because the more surface area we have available, depending on the structure, is going to allow that sense to work more effectively, okay? So that retina in the back, we stretch that nice and wide so that when we have light bouncing off the lens, there's nerves that extend out. The optic nerve branches out into that retina so that we can gather as much of that light to allow our brain to picture together what we're seeing, okay? Now below the retina, we have the choroid, okay? So the retina is this lighter tan layer. The choroid is all blood vessels. The choroid is what provides blood to the retina, okay? Like everything in our body, we need to supply blood to our eyeball because if we don't, we start hypoperfusing. Right? We want perfusion. What are the 3 things we need to perfuse our cells again? Oxygen, glucose, waste removal. Very good, Jillian. Very good. So, our eyeball's no different. And last, but certainly not least, when we're talking about the eyeball itself, is the white of our eye. The white of your eye is the sclera. Okay? Now, some of these terms you will see again, like sclera, pupil, iris, cornea, lens. Where are these things? They might come up in a couple weeks or so. I would just maybe remember them, okay? Spend some time in them. And then fun fact about our eyeball, our lens actually inverts the images that we see. So as we're looking at something that's right side up, our lens views it and flips it upside down. Well, that optic nerve goes all the way back to your occipital lobe, okay, optic occipital, and your occipital lobe flips the image right side right, so you know exactly what you're looking at. Now this happens, instantaneously. It's not truly instantaneously. There is a slight delay to it, but it's millisecond delay. Very, very, very quick. Okay? Questions on any of that stuff at all? Okay. So, like I said, I over-explained. We're going to talk about some other things. Okay, so clear jelly-like fluid near the back of the eye is the vitreous humor. And then in the front of the eye, there's a fluid called aqueous humor. Aqueous humor lives between the cornea and the iris, okay? That's the fluid that's in the very front of your eye. Has anyone ever heard of floaters, or do they see floaters?
Yeah.
That's where they float around. It's part of where you see them.
So
It's not liquid. The floaters are something else. I don't want to mislead you, but I know if you have too many of them, it can be a bad deal. So go see your ophthalmologist. Ophthalmologist? Optician? I don't know.
Eye doctor.
Thank you. Eye doctor, we'll call it that. Yeah. Now, in the front of the lens, the fluid's called the aqueous humor, which can leak out with penetrating injuries. If you're anything like me, I can look at about 95% of injuries after they happen, and I'm just fine. There's a couple of categories that really make my skin crawl. One is bugs, because gross. 2, eye stuff. If you've ever seen like fish hooks in eyeballs, man, horror shows. If you're curious, there's a couple of pages on Instagram I like to, I follow myself, but Savage Paramedics will do that one. They'll show some of those from time to time. There's another one called Medical Talks. Both of those will show very graphic medical images, but some of them are really interesting. They'll go into a really long description about what you're seeing and why it's happening. It's worth your time. Or if you don't want to, horrify yourself and sleep clearly at night, that's fine too. So, moving forward, the conjunctiva. The conjunctiva, if we pull your eyelid down, is the tissue you see. That's the pink tissue right in there, okay? So the conjunctiva is basically that, the protective layer or the smooth layer for where our eyelid touches our eyeball, okay? Moving forward from there, we have our lacrimal glands. Lacrimal glands produce fluid and keep the eye moist. What's another name for the lacrimal glands, you think? Our tear ducts, yeah. Our lacrimal glands live on the medial side of our eyeball, right, closer to our midline. Our lacrimal glands are our tear ducts, our tear ducts. I need to start doing like the Anchorman things when I'm warming up my voice in the mornings. I gotta remember more of them. Okay, questions at all on this stuff? Yeah, Carter.
So the conjunctiva, is that the same name for the bottom as well as the top one, or is it?
Is the conjunctiva the same name for the top and bottom lid? I believe so. The top one is just harder to check, so we don't really rely on that one too much. I mean, you can try, but like, you ever have that friend who flipped their eyelids? Like, yeah, exactly. They're weird. We don't trust those people very much. But moving forward, right? We have the conjunctiva. So that conjunctiva actually is we can use it for as a sign. It's a very good indicator for anemia, actually. Anemia we'll talk about way down the road, but it's basically a red blood cell shortage or a low red blood cell count. So if you check that, instead of that nice pink color, it'll be a pale color. Fun facts. Okay, now the sclera, the white fibrous tissue that helps maintain our globe's shape. Okay, so the white of your eye is the sclera. It's fairly tough, it's fibrous. Anything fibrous has a good amount of durability to it. Obviously our eyeballs are not impenetrable, they're not perfectly invincible beings, but they do their best. They're fairly tough. Now, on the front of the eye, the sclera is replaced by a clear, transparent membrane. That's the cornea. Okay, so the sclera turns into the cornea, which is clear, which obviously we want it to be clear so we can see through it. Okay. Now this allows light to enter the eye, and then with the iris being the circle muscle behind the cornea that will open and close depending on our light exposure. Okay. Couple of fun facts. Does anyone know the type of cells that live in our eyes that help us see color or light? Yeah, go ahead. The rods and cones. You remember which one does what?
Yeah, so cones are for color and rods are for like dark and light.
Yeah. Yeah, so rods help us register the light in the room, and then cones let us see the colors. Yeah, fun facts. Which is why at nighttime, you actually see in black and white. There's not enough light to register the color. Pay attention next time you're walking through your house in the dark. I mean, you should pay attention when walking through your house in the dark anyway, but pay attention to the colors of things. Okay. Now the pupil is the opening, the center of the iris, allows light to move to the back of the eye. The back of the eye at that retina is where we have the vision starting. Okay. Now, some med term, this is one that I would maybe write down because it can come up again. Aniscoria. Aniscoria means that people are born with two different size pupils. And it's one of those things that you're going to want to keep track of. If you notice it in a patient, ask about it early. Okay? The reason I say that, and we'll talk about it in the next lecture today, is a sign symptom of head injury is what we call a blown pupil, or one pupil will be really large and not reactive to light. The other one will be will function normally when we shine a light into it, okay? Remember that. I've had one patient, it was a trauma, a guy fell. I didn't get a good chance to look at his eyes. He was just being rolled out to the ambulance pretty quick. And once he got in the back of the ambulance, I saw it, and I was like, oh man, I missed something big. And I was like, and he's like, yeah, my eye that's normally like that. I have anoscoria. I was like, oh, whew, because I was worried as an older guy who fell, right? You just got to double check some things, okay? Now, behind our iris, we have the lens, which once again helps us focus images on the back of the eye or on the retina, which allows that optic nerve to gather that information, send that info to our occipital lobe. Bingo bongo, you've got vision, okay? And then depending on your lens shape, you could have vision issues, nearsighted, farsighted.
So with anoscoria, they'll know they have that usually?
So anoscoria, they'll know they'll have it, yeah. If they don't, if you're like, hey, do you have different size pupils? And I would maybe avoid the term anoscoria, but is it normal for you to have different size pupils? Yes or no? Because that'll guide our situation. But yeah, if they have it, they'll know they have it. I mean, I'm sure you can imagine what your eyeballs look like without looking in a mirror, right? We've all done it. Okay, yeah, Carter.
In case of like anoscoria, if they're not born with it, if it's from like an injury from forever ago, is there a different term for it? Is it just still that?
If it's not born with it, if it's like occurred from trauma, I don't want to mislead you on this one. I believe it would still fall under anoscoria. I've seen that one time too for an older guy got hit with a rubber band and it broke his iris. I don't know if it necessarily would be anoscoria, but it still is worth asking, right? Normal finding or not. But I'm not sure. I'll look into it. Okay, so back of the eye. I feel like I'm kicking a dead horse at this point, but it's okay. Right? The more we kick this horse, the more that we retain stuff. So the retina contains our nerve endings. Retina in the back of the eye responds to light by transmitting nerve impulses through the optic nerve to the brain. And the retina is nourished by a layer of blood vessels called the choroid. Now, you can have retinal detachments. You can start to separate that layer of your eye, which is going to affect your vision. Has anyone seen Rocky in here before? Right? I'd hope everyone's seen Rocky. It's a great film. But when he starts losing his vision, right? I think it's Rocky 2 is when he's like, I can't see, coach. He basically has a retinal detachment starting. It's pretty common with combat sports, but any sport where people can take a shot to the head, especially if they're not ready for it, it's not an uncommon injury pattern that you'll see. Yeah. Questions at all on any of this stuff? Cool. Is the optic nerve also our blind spot? There is a blind spot on the optic nerve, which if we actually go back to this image here, you can kind of see it right there. That dark spot is a blind spot. Yep. Yeah, the eyes, or the brain is crazy because obviously our eyes are working all the time. If your eyes are closed, they're still working, right? So even like us looking here, you can see your nose all the time. Your brain just filters it out because it's unnecessary information. You know it's there, it should not change, right? So it's kind of crazy that just because you're seeing something doesn't necessarily mean that you're seeing the whole picture. Okay, so moving into injuries of the face and neck. Now, it can often lead to partial or complete obstruction of the upper airway, right? Which is why if we throw it back to the assessments chapter 10, A, B, C, we got to check that pretty quick, right? If we're worried about the neck, right? If there's vomiting, bleeding, just even swelling, that can start closing off the airway. Okay, so several factors that can contribute to that partial or complete airway obstruction. Blood clots from heavy facial bleeding. Someone has direct injuries to the nose and mouth, larynx and trachea, or if someone dislodges teeth or dentures in the throat. Did I tell you guys my dentures story? Okay, so it's Thanksgiving 2022. Holidays are kind of an interesting thing on the shift because it's either you're really busy or you're not, which means people are having a good day, which we kind of bank on people having bad days. I digress. So we dispatched to a cardiac arrest at a private residence. When we show up, it was really weird. We're working Mima in the corner over here, and there's like 40 people in this house, and they're like, oh, it's good to see you, giving hugs. And it was like, this is a weird dichotomy of this moment, right? Death and life. But we go, and I'm a student at this, or not a student, excuse me, I'm a trainee at this point. I'm in my FTO. and we're doing the cardiac arrest, and my medic mentor said, or preceptor said, hey, I want you to intubate this patient. Just hadn't had a lot of tubes, so I was like, yeah, sure. So I tell everybody, hey, I'm gonna go intubate this patient. And they say, cool. Well, did I show you guys the Lucas device, the CPR Lucas device? There's a back plate to that. Well, I get my blade out, I say I'm intubating. Everyone says, cool. I put the blade in her mouth. As soon as I put the blade in her mouth, her whole head came up at me, and I had two thoughts instantly. First one was zombie. Second one was that I just broke this woman's teeth. I broke all of the teeth out of her head, because that metal blade is a pretty rigid thing. You guys have played with the Airway mannequins. You felt the teeth clicking, right? That's why it clicks, because if you click them, you're breaking teeth. So I thought I broke her teeth, and I felt terrible in that moment. Well, what had happened was that the fire crew and my FTO had decided, let's raise her arms and get the Lucas plate underneath as I had the blade in her mouth. Now, where I was really, really fortunate was it was just 2 sets of dentures. So they just were all mishmashed in her face. It's like, plop, 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 get those out of there, clear the airway. So where I'm trying to go with this is if they have loose fitting dentures, just take them out early, right? If they were convincing, I didn't know they were dentures until I obviously knew they were dentures, but if you can find out if they're dentures, get them out of the way early, especially if we're worried about facial injuries. It's just another airway obstruction, right? You can't breathe through solid plastic. So, other factors, swelling that accompanies direct and indirect injury. Anyone ever had a black eye before? Your eye starts swelling shut pretty quick, right? Swelling in soft tissue can be pretty darn quick. Now there's kind of an inverse to that as well. Swelling can be quick, but bruising can take time. For those of you who have had a black eye, did that black eye show up within 5 minutes? No, it took about a day or two, right, for it to really come to fruition. Same thing. We'll talk about it when we get to neck or when we talk about strangulation. But ligature marks, anyone know what ligature marks are?
The handprint.
Yeah, the handprint, or like if someone hangs himself with a rope, the rope mark. That can take hours to days to develop. So if we're dispatched out to a strangulation patient and we show up and we don't see any marks, we're like, well, it would look like you got strangled. It might not necessarily be the case, right? Just because it might take some time. Soft tissue. Now, other potential airway obstructors. Airway may be affected when the patient's head is turned to the side. I think that just is pretty sensical, right? If you think about yourself laying on your back, you can breathe. If you lay your head to the side, you can still breathe, just not as easily, right? You're kind of twisting and manipulating the airway. And then other things to consider, possible injuries to the brain and or cervical spine. Well, under C1, C2, we have an extension of our brain. What am I referring to here? The brain stem, right? What does our brain stem control? Critical life functions, breathing, heart rate, right? So if we have issues where we injure the C1, 2, 3, we run the risk of them not breathing, right? If they have a complete separation, we call that an internal decapitation, right? But they're not breathing, and here's the kicker, is they're probably not going to, right? Because the whole breathing mechanism is busted, okay? Just things to consider, right? That's why when I'm saying read the mechanism, just because they got hit in the face doesn't mean they just got hit in the face, okay? Make sense? All right. Questions at all? Okay, so soft tissue is just a quick little thing here. So face and neck, extremely vascular. We have a lot of blood vessels, a lot of nerves in our face and our neck, because obviously that's a very important sensory area for us. I almost said sensical, but very sensory area for us, okay? So face and neck, extremely vascular, so swelling can be more severe. Remember, swelling is blood or fluid leaving vasculature, okay? That's what we're seeing. Now the skin and tissue in these areas have a rich blood supply, so if they're after blunt trauma, they can have pretty gnarly hematomas, right? So this, obviously on this gentleman here, is a pretty big hematoma. Can someone tell me what a hematoma is? What? Like a swollen ball? That's not partially there. I heard bruise. So what's another word for bruise in medical terms? Starts with a C. Contusion, right? A contusion is a bruise. A hematoma is a bruise also, but here's how you kind of think about it. Oma in med term means mass. So anyone ever been hit so hard that they have like that hard spot in the middle of their bruise? That's a hematoma, right? So the oma means mass. You can feel the hard spot. Versus if I bump something and I just got a little bruise on me, there's no hard spot, that's a contusion. So they're different things. They're similar, but they're different. Okay, it's more of like a contusion will progress to a hematoma the more blood that shows up. Okay? Questions on that at all?
Blood, so it's just blood mass.
Say that again?
And hemo is blood.
Hemo is blood, yeah.
Blood mass.
Yeah,
Mass blood.
it's a mass of blood. Exactly. You're getting smarter. I knew you'd get there.
Got a good teacher.
Flattery might get you somewhere. Okay. So moving forward, dental injuries. Mandible fractures, very, very common, depending on the circumstance, with the more frequent or most commonly seen variations being motor vehicle collisions, so car wrecks, or assaults. Okay, now some signs of mandible fractures. Misalignment of teeth, numbness in chin, and an inability to open the mouth. I've only ever had one call that was for sure. I felt pretty bad for this guy. He was out at the prison. He had gotten jumped on a Friday. We were picking him up on a Sunday. This guy was in a bad way. He had fractured his orbit, and I think it was like 4 spots in his mandible, and I think it was 6. So his whole teeth, when they say misaligned teeth, that can be a couple of variations. One, if I like broke the middle of my mandible, my teeth, instead of being nice and even, could be a little bit obscured or right uneven there. But this guy, he broke it up here. So his whole jaw was shifted over to the side. Okay, so he obviously couldn't talk, could barely open his mouth, because if he opens his mouth, he's gonna have crunchy bone crunching on each other. And I don't know if you've ever experienced that. Like, I've had it in toes and fingers, not in my face. I couldn't imagine, okay? So just keep that in mind. Now, what do you think the guy's skin looked like around that area? Soft tissue. Pretty bruised up, right? And he got jumped on a Friday. We found him on a Sunday, so that had plenty of time to start showing up. He was purple and blue, basically halfway across his face, okay? So it does happen. Make sure you're double checking, okay? This is one of those things that as we're doing our physical assessment, you show up, someone gets punched in the face, hey, let me see your teeth, give me a smile. Have them physically show you their mouth, because we want to see if teeth are aligned. And you can ask them, right? Any loose teeth, you feel anything wiggling? Does anything feel like it's not even or where it should be? All great questions to ask. Now, in a perfect world, they're going to be like, everything's fine, I don't hurt, I don't want you here at all. Okay, but do your due diligence, okay? Make sure you're looking. Now, maxillary fractures, right? The top teeth. In comparison to the mandible, maxillary fractures, usually blunt force, usually extremely high energy impact, okay? This is a sturdy, sturdy bone. So, for you to break that, you got to get hit pretty darn hard, okay? So signs of maxillary fracture: massive facial swelling, okay? So you'll start to see it around their nose. I've seen some pictures of these. I haven't had this one personally as a call type, but in the pictures, has everyone seen the Grinch, like the old Jim Carrey version of the Grinch? They kind of look like those Who's. Their lip will start to swell so bad, their face, that it kind of rounds out the front of their face, okay? But when you go to palpate the face, they might have unstable bones. And then once again, misalignment of teeth. Now, if we're talking about maxilla, are we talking about the bottom teeth or the top teeth? Yeah, top teeth, right? So double check. Now, fractured or avulsed teeth are common following facial trauma. We'll talk about what we do with these in a little bit, but fractured, so broken teeth, or avulsed teeth. The tooth is either sheared off or pulled out, and it's traumatically, okay? I had a buddy, played a really dumb game back in college, but it was basically a drinking and punch each other in the face game. It's not a good game I'd endorse, and he actually ended up getting hit by a guy so hard when he woke up the next day, he felt his teeth and they were all split in half, his back molars. So yeah, maybe make good choices, or maybe not that bad of a choice. But I digress. Questions on dental injuries at all? Okay, we'll talk about treatments and things of that nature here soon. So I kind of talked about this with shock, right? We're going to start to see the scene size up, primary assessment, history, secondary assessment, reassessment. I'm not going to stop much on those. If you're curious, spend time in your book, spend time in the literature. If there's something big, I'll stop. But scene safety, observe for hazards and threats. That kind of goes across the board. I will extend, if you're going to be dealing with a potential assault and there's a violence-related kind of, or a violence kind of component to this call, maybe just make sure everything's safe, right? Double check your scene, because if it's not safe, we don't go in, right? And we can always get PD involved if we're worried about it. So part of the scene size up as well, read your mechanism. I know I was kind of digging in on it last lecture as well. Read the mechanism. The mechanism can tell you a lot. It can give you a decent guess about what's going on before you get there. With the caveat, take it with a grain of salt, because dispatch is not perfect. There are people on the phone trying to give you details, visual details of something they're not there to see. Okay? Primary assessment, ABCs, which if we're talking about face and neck, we're worried about airway and breathing. Okay? General impression, airway, breathing, circulation, transport decision. If someone has a severely blocked airway or they have a lot of teeth floating in their mouth after an assault, how fast do you think we're driving? Probably pretty fast, right? Depending on how obstructed they are. Same with blood. Okay, history. If we're talking trauma, history is not necessarily the most important thing. It could have factors though, right? It could be have implications. Like if we're talking about a fall and it's an older person, they have something like osteoporosis or weak bones, that's relevant, right? That would make sense, history relevancy. But a lot of it's like, well, if I had my appendix out when I was 13, does that, you got punched in the face? There's no correlation, right? Make it make sense. Secondary, that's the hands-on. We're looking for DCAP BTLS. Have we talked about DCAP BTLS yet? The acronym or mnemonic? Yes? Deformity, contusions, crepitus, okay. Then I'm not gonna spend time on it right now. Hands-on. And then another one I do like that's in here too, when you're evaluating the eyes, make sure you're checking vision too, right? And ask the questions. Blurred vision, does your vision feel normal? Can you see my fingers peripherally? Okay, but all questions worth asking. Cool. Reassess every 5 if critical, 15 if non-critical, and moving on. So what do we do to treat these soft tissue injuries? So treat soft tissue injuries to the face and neck the same as you would everywhere else in the body. XABC, what's the X stand for again? Exsanguination. What's exsanguination mean? Major bleeding, bleed all your blood, okay? So follow your standard precautions, gloves, mask, goggles, gowns if needed. Okay, now in absence of life-threatening bleeding, first thing we gotta do, ABC, right? If we don't have X, we move on to A and then B. And remember, we can't move on from A or B, we can't move on from A until we know the airway's clear. We can't move on from B until we have a plan for breathing. We can't move on from C until we've checked everything, we've controlled that bleeding once again, okay? And then, like always, avoid moving patients who have a potential neck injury. When it comes to controlling bleeding, it's gonna be direct pressure, dry sterile dressing. If we're talking about the face and neck, are we ever gonna put tourniquets on? No, very good, smart answers. So, roller gauze wrapped around the head, hold pressure with the dressing in place. That's gonna be a common one. You can have a picture of it in your mind. They've wrapped gauze around somebody's head. And then usually there's a Coban, which is the stretchy stuff if you donate blood. They'll put that around there as well as a double down. It works pretty well. Okay, I would say in my experience with a lot of these like more superficial head injuries, like just bleeders, it works pretty well. Stops most of the bleeding most of the time. Okay, most, if not all of the bleeding most of the time. Now, do not apply excessive pressure if we're worried about a skull fracture. Do I need to explain why that concept exists? If they've got a skull fracture, we don't want to go pushing things inside their head, right? Now, if we have exposed brain, eye, or other structures, we're going to use a moist, sterile dressing. If it's supposed to be moist, let's keep it moist, okay? Downside of a moist dressing, if we're treating, what's our treatment for shock? What are the 3 things we got to do? You guys remember? Lay them down, supine. What'd you say? Keep them warm. What's the last one? Oxygen. Well, if we're putting a moist dressing on, it's February. How do you think a cold, moist dressing is going to do for temperature control? It's not going to do good, right? So a lot of our ambulances carry saline warmers, so you'll have warm saline. Just make sure you're doubling down on using that. Make sure you're keeping, if it's cold outside, your ambulance nice and hot, okay? If there's injuries that do not break skin, but there's swelling, we can apply ice, okay? Apply the ice. That's going to bring down swelling temporarily so that when we get to the doctor, they can do a thorough investigation. They're not fighting through a bunch of swollen tissue, okay? And then for soft tissue injuries around the mouth, check for bleeding inside the mouth as well. Remember, bleeding in the mouth can also be an airway obstructor, okay? For avulsions, what an avulsion is if basically they're taking a patch of skin. Okay, the easiest, or not easiest, the way I think about an avulsion is like scalping someone. If you were to cut their hair off, take the skin off the top of their head, that's an avulsion. Okay, now it doesn't have to be completely off. You can have an avulsion that's hanging on with a piece of skin. Okay, so if we find portions of avulsed skin, that skin has been sliced off. Okay, place it in a plastic bag, keep it cool, but not directly on ice. If you put it on ice, you can actually start to destroy the cells. We just want to keep it cool, slow the cell function, and then make sure you deliver to the emergency department. I like how it says label too, like someone's going to confuse it for a piece of ham or something. Maybe don't do that, but yeah, make sure you let them know, hey, we have the skin, because they can graft that back on. Okay. Now, if there's still skin attached, right? It's an avulsed flap. They've been scalped, but only a portion of it, there's a small portion holding it on. You're going to put the flap back down, adjust the toupee, make sure it looks as normal as possible, and then you're going to wrap it with a dry, sterile dressing, okay? Same thing, if we have a flap of skin hanging off, we're going to lay it down, wrap with a dressing, dry, sterile. Questions on that? Okay. So, injuries to the eye, pretty common in sports. Actually, before we get too far, how's everyone doing? Would a break benefit anyone? Cool. We're going to go for a little longer then. Outvoted. So, eye injuries are common in sports. Now, remember with eyes, right, obviously the worst case scenario besides having an eyeball removed is blindness, so loss of a sense. So that can be a lifelong complication. Okay. And then after an injury, pupil reaction or shape and eye movement are disturbed. Okay. Carter kind of mentioned it earlier. If someone damages their pupil, right, that's a lifelong thing unless they can surgically repair it, which for the most part, I can't say if they will or won't, but it will affect them, right? Obviously, any sort of damage to a structure that is irreversible or has irreversible effects is going to be long term. David Bowie. Yeah. What? How did his?
I think it was like a car accident or something, if I remember correctly. And then he had
heterochromia, different color eyes. Yeah. I knew that one. I didn't know he had the pupil thing.
The guy from the Labyrinth.
Huh?
Is that the guy from the Labyrinth?
Yeah. Yeah. I mean, his music's more popular, I think, than the Labyrinth, but I've heard good things.
Oh, so it was an actor?
Yeah, that's fair. Okay, so we're going to start a fight. So moving through. So treatment starts with a thorough examination, right? So if we're looking at the eyes, make sure we're wearing our gloves, goggles as needed, mask as needed. Try not to aggravate the problem, right? Don't go poking at the eye. Be gentle with it. And then look for abnormalities or condition that may suggest the nature of injury. I don't like this as nature there, mechanism of injury, right? Now, most of the time, if they're conscious, they're going to be able to tell you exactly what happened. If they're not conscious, you might have to do some digging, right? A little Sherlock Holmes. Eyeballs there, windows there, right? Just start putting it together. So, foreign objects in the eye. The orbit protects the eye from penetration of large objects. Okay, so even small objects can produce severe irritation. And then what you got to do? You got to irrigate it with saline. Okay, now we will carry big old jugs. We used to carry 2-liter jugs of saline on top of our liter bags. So you will have options. Okay, but irrigate with sterile saline will frequently flush away loose particles. Has anyone ever gotten something in their eye they had to go to the doctor and get it flushed out? Did you have to put the little suction cup under your eyelid and they like spun the fluid? It is not a comfortable thing. I had it. I was helping my mom put up Christmas lights when I was like 13, and she kicked some of that roof gravel, got right in my eyeball. Yeah, it's not a comfortable thing, but obviously it worked. Now, before we get too far, let's just kind of sensical this moment. If we're going to irrigate someone's eye, should we irrigate from the nose or from the side of the eye? From the side? From the nose. Like from the bridge of your nose or from the side of the eye? From your bridge of your nose. Why? Yeah, push it away, right? If they're laying here and we're irrigating the eye from here, all we're doing is creating a pool of water that now might have the sand, I'm just making that up, but might have the sand floating around in it. We haven't dealt with the problem. So start at the nose, flush it away. Got it? Cool. Okay. Now, always flush from the nose. to the eyes, towards the outside, avoid flushing material into the other eye. The last thing we want to do is contaminate it. Yeah, that's a really handy dandy little MacGyver thing there. I actually was recently, I'll make one maybe today and I'll show you guys how to do it. But essentially what you do is you take a nasal cannula, you clip the end, you'll attach it to a syringe full of fluid, and it'll just stick onto it there. And then you'll give the patient the fluid. That way they're controlling and it's not jarring them every time we push it. But they'll push, and then we'll tape that to their eyes like that. And then when they push that syringe, it'll actually start flushing their eyes out. It's a real MacGyver thing, yeah. Yeah, oh yeah. Yeah, that probably feels, I can't tell if it's a paid actor, he's really struggling. If it's someone who's actually got painful eyes, that probably feels great. Okay, now, a foreign body can leave small abrasions or little scratches on the conjunctiva, right? So it can be like the internal lining of the lid. There can be a swelling associated with that as well, okay? Now, gentle irrigation may not wash out foreign bodies stuck in the cornea or lying under the upper lid. So you may have to have the patient lift their eyelid off, okay? Give them a task because they're gonna try and fight you the whole time. If you give them a task to hold their eyelids open, they might fight you. But if you give them that job, right, they tend to kind of be more cooperative if you give them options. If they're holding their eyelid and they're fighting it, you're gonna have to hold their eyes open and do what you gotta do, okay? But understand there could still be something under that top lid, so we could be doing more damage. Just do your best to try and irrigate everything out, okay? Has anyone ever seen the movie End of Watch? It's a police movie. It's a very, very sad movie. It's a great movie, but it's a sad one. Well, there's a scene in End of Watch where this guy, they're police officers in South Central California. A guy gets stabbed in the eyeball, and he's like this when they walk by, and he's got a knife there, and he's like, guy went that way, which I just thought was impressive that he still pointed. But if we have a foreign body impaled in the eye, okay, a couple of things we got to do. First, bandage it in place to support it. Now, you can get creative. This is one that a military guy showed me, okay? He took a SAM splint, cut it. So if we have something impaled, you can put it on the eye like this, and it'll hold that secure, and then we'll just tape this to their face, okay? But they also make like these little donut collars. You can take a bunch of gauze and roll it up so it's a nice firm collar as well, okay? But you gotta support that. Obviously, we don't wanna push that deeper, and we don't wanna pull it out. We don't ever pull out foreign objects, impaled objects. We'll talk more about it next Wednesday. There's two caveats to when we do. If it obstructs the airway, or if it gets in the way of CPR, okay? But we'll talk about those again later. Now, back to the eye. We're gonna cover the eye with sterile dressing. Now, if we're gonna cover one eye, if we're, as normal humans, if I look left, does one eye look left or both eyes look left? Both. So what do you think that means when it comes to covering eyes? Should we cover one or both? Both, right? Because the last thing we wanna do is have them have one eye, and then they're looking around and you see that knife just kind of wiggling around or whatever, wiggling around with the eye movement, okay? If you're gonna cover one, cover both, because they work in conjunction. If they don't, it could be either head injury or they got a really weird talent. I don't know how else to describe that, okay? But cover the eye, moist sterile dressing, surround it with a donut-shaped collar. Now, when you see or suspect an impaled object in the eye, bandage both eyes with soft, bulky dressings to prevent further injury. Once again, we don't want them looking around with that thing wiggling back and forth and potentially working its way deeper and deeper and deeper, because obviously we got some important stuff in here we don't want to damage.
Have you seen the Nerf dart video?
The what one?
The Nerf dart video?
I don't know if I want to see a Nerf dart video. Sounds horrific. Is it?
They got suction cup Nerf darts.
Oh. Oh.
It's just wiggling around.
Oh, I hate that. I hate that. Eyeballs make me uncomfortable. I told you, we talked about it. I don't like it. Oh, God. So, moving on. Burns of the eye. So stop the burn, prevent further damage, right? If there's burns, thermal burns, get them away from the thing that's hot. Now, if we're talking about thermal burns, do you think people are gonna burn their eyeballs necessarily? It's possible, but if something's coming towards your face, what's the first thing you're gonna do? Blink. So if someone's got a fire going towards their face, you think they're gonna burn their eyeball or their eyelids, right? So they'll burn the exterior portion of their eyelids. That typically is the more commonly burned thing. Not to say you can't burn the eyeball, the globe itself, but the eyelids tend to take a lot of the damage because they're gonna close their eyes. Now, if they have chemical burns, Acid or alkaline, can be either, okay? With either of them, we're going to flush the eye with water or saline. We carry the saline, that's what we're gonna use depending on your agency, okay? Now, direct the greatest amount of irrigation solution or water into the eye as gently as possible. Just do what you can. We're not trying to cause long-term damage, right, by pushing that even deeper and being aggressive with our flushing. Now, when it comes to acids or alkalines, or alkaline solutions, acids kind of, is anyone taking chemistry? I know you've taken chemistry. Any chemistry people in here? So, you know when you've dealt with acids, it kind of looks like water, right? It moves, it acts like water. What about alkaline solutions? Like slimy, like viscous, like an oil, right? So think about like toilet bowl cleaners. Toilet bowl cleaners are an alkaline solution most of the time. They have that kind of viscosity, sticky, almost, not sticky, but it's slimy, that's a good word, right? So also differences, acids are gonna start burning immediately. Alkaline tends to take a little bit of time. Now, depending on the strength of the alkaline solution, that little bit of time could be a minute to seconds, right? It's not gonna be as instantaneous as an acid. But just keep that in mind. It doesn't matter what we're seeing. We're going to irrigate them the same, but the reason I bring that up is because the damage you see could be different depending on the strength of the acid or the alkaline or basic solution, okay? Questions on that at all? Yeah?
How long do you irrigate an eye for?
How long what?
Like, do you irrigate an eye for? Like, are you irrigating from when you get to the patient until you take them to the hospital?
How long do we irrigate an eye for? I'm glad you asked because it's about 20 minutes. We're going to get to it in a second, okay? But yeah, no, that's a good question. You're going to irrigate the eye for about 20 minutes or so, okay? Now, these are just a couple of different examples, right? So this is the MacGyver thing, which I'm embarrassed to say I truly learned how to do like 6 months ago. So I used to do this. I used to use just a jug, hold their eyelid open, and just gently do that. B there, the one with the sink nozzle, that's like if you think of your high school chemistry lab or like industrial areas, they'll have those eye wash stations. And then worst case scenario, if you have to fill a bin with saline, hold their eyes open. I love how she's just reflecting on life choices in this picture. She's like, I screwed up. Yeah, totally different game. I won't talk about it on camera. We'll talk about waterboarding later. So. If you had an eyelash in your eye? Well, I would say an eyelash is a different conversation to an acid, right? And then another thing is if we're going to be irrigating into this bin, where's that going? Into the bin we're going to keep irrigating into, right? So you could potentially just be reintroducing it over and over. Yeah. I mean, you're not holding the head, you know, but you're going to do it for a couple of seconds. And you're going to keep them in the loop, okay? But like I said, we're going to use the jug or the fancy one instead. Okay, moving forward. So chemical burns, once again, we might have to force the lids open, inside corner to outside corner. If the burn was caused by an alkaline or strong acid, here you go, Ella, continuously for at least 20 minutes, okay? After irrigation, apply a clean, dry dressing to cover the eye and transport. Now here's the reality too. You can irrigate and you're going to flush this eye for 20 minutes. They're still going to be awful uncomfortable, okay? So just have that understanding. They're probably not going to be chipper after this, okay?
Do you ever like tape like at like kind of help hold it open?
Like tape. So do we ever tape like the lids open? I haven't. I could see the thought process behind it. The only reason I lean against it is because we don't necessarily want to leave their eye open, right? Where it's more controlled with our fingers. Good question though. Okay, so thermal burns. During a fire, the eyes will close to protect from heat and the eyelids will burn. Transport promptly without further examination. We want to get them to definitive care as quickly as we can, okay? So cover both eyes, sterile dressing, sterile saline, and then apply eye shields over the dressing. We don't carry eye shields, but we used to have those face shields, like the ones that people wore during COVID. It's just an extra reminder of like, don't bump this person's eyes, or if they go to rub it, they're gonna stop themselves, okay? Just another layer of protection. Now, things to consider. What kind of, it says right there, cover both eyes with moistened sterile dressings. Why do you think we want to use moist dressings with these ones? And this is going to be counterintuitive to something we'll talk about later, but why do you think we want to use moist dressings, not dry dressings?
What?
To keep them from drying out.
Kind of like a soothing.
What?
Kind of a soothing thing to kind of keep it moist where you like less irritated, don't want to touch it because of the dry.
Maybe.
What doesn't, when you're burned, your body creates a lot of like
Uh-huh.
water that shoots, not water, but like.
You're on the right track.
So if you put dry on, it'll stick to it.
Yeah, so plasma. Remember when we burn ourselves, we have plasma leaving. That's that sticky, slimy. Has anyone ever gotten like a turf burn and then put clothes on top of that turf burn? You wake up the next morning, you're like, ooh, that's stuck, right? I used to burn my hips. I played soccer in college, slide tackling on turf, bad combo. Yeah, that'll stick, right? So imagine now it's their eyelids that are stuck, right? A little bit less comfortable. But where I say it's counterintuitive, and we'll talk about it later, is because let's say the body, a lot of the body is burned. Well, we got to maintain temperature, right? If we give them moist dressing because they're burning off their skin, their insulation layer, we actually need to use dry dressings because moist dressings run the risk of cooling them off too aggressively. Now, put yourselves at ease. When they're going to remove those dressings, they're going to get them wet in the ER because they got to debride and clean that wound anyway. Okay, but dry dressings just to maintain temperature later. But we're kind of I'm getting sidebarred a little bit. We'll keep moving forward. Now, light burns, infrared rays, eclipse light, laser beams can all cause significant damage. I'm hoping none of you guys looked up at the last eclipse like certain people we know that got famous for it. But retinal injuries caused by exposure to light are generally not painful but may result in permanent damage. And then severe conjunctivitis, right? So conjunctiva, that layer of tissue inside our eyelid, itis, inflammation of our inner eyelid, usually develops with redness, swelling, and excessive tears because it's uncomfortable. It's going to try and lubricate and defend itself. Has anyone ever sunburned their eyeballs before? It's not fun if you have. Dry, itchy, scratchy, uncomfortable. Okay, but yeah, you're going to be tearing a lot trying to lubricate your eye. For lacerations of the eye, require very careful repair to restore appearance and function. Now, bleeding may be heavy, but it's usually controlled with gauze, manual pressure, okay? Now this is gonna be, obviously if they have a cut eyeball, we don't want to press directly on that eyeball because then we're just separating and causing more problems. You're just gonna be trying to gently control that with some light pressure. I would have the patient hold it for you though, if you can, yeah.
Where would like a flash burn from like welding?
Yeah, so where's flash burning? That's gonna be a light burn. Yeah, yeah, that's why they have to wear the face shields, yeah. It can burn your retina, yeah. More often than not, it's a scleral damage, but if you're staring at the arc when you're arc welding, yeah, it'll destroy your retina. It's the same thing as if you look in a laser, like let a laser hit your pupil, it destroys your retina as well. Yeah. Okay, So on rare occasions, the eyeball may be displaced from its socket. Do not attempt to reposition it. We don't just go, there you go. We don't do that, okay? Cover the eye, stabilize with moist sterile dressing. Cover both eyes to prevent further injury, have them lay supine. So how I imagine this going, right, is that if their eyeball is hanging out of their head, there's no just like gentle dressing, right? That doesn't really add up. But if you lay them supine, cover one eye, put down some wet gauze around that, rest the eye, gauze over the top, okay? Last time I had an eye appointment, I talked to my doctor about it and I was like, just curious, if someone's eye pops out, can they still see? Could they be like, hey, and they can still see what you're doing? And she said probably not because the vessels aren't long enough, so they probably tore halfway through that looking. And I was like, well, that's a disappointing answer, but it's the truth. I gave you an answer. Yeah. Oh yeah, where they bulge them. That's not a good thing, I don't think. But moving on, so we have blunt trauma to the eye, okay? So hyphema obscures all or part of the iris. Hyphema is essentially just a fluid type that obscures vision, okay? It gets mixed into that aqueous humor. Now, an orbit fracture is a fracture of the bones that form the eye floor, support the globe. We talked about the orbit, right? Surrounding the bone, surrounding the eyeball. So that's a pretty frequent one. And then often if they're gonna have that blunt trauma that's just fractured the orbit, they run the risk of a retinal detachment as well. I had a buddy in high school. He was a catcher on the baseball team at practice. They were doing batting practice. He wasn't paying attention. He had his mask off. He turned and he caught one to the cheekbone. Now, I didn't play baseball, so I didn't know till the next day when he was sitting in government class with me. And I was like, oh, you're really cool wearing your sunglasses inside. And they lifted it up and I was like, ooh, put them back on. His eye was super, super swollen, big, purple, puffy. It's gonna be very obvious where that blunt trauma hit them. Yeah.
In the case of like orbit fractures,
Okay.
is it like if it's an open fracture, is it more of a concern that the bone is sticking up into the globe or less?
So with orbit fractures, if it's open, are we concerned about bone fragments? When you say open fracture, are you referring to the bone itself being open, or are you talking about the skin exposing? So if it's skin exposing, it's not technically an open fracture of the skull because we're not seeing brain or internal activity. So if it's just skin exposing bone, you're just gonna kind of cover that up. Now, if there's broken pieces of bone, that might be a medical control call of like, hey, this is what I got. I don't know the best way to splint or to bandage this up. So when in doubt, just remember medical control is always on your team. Okay, so eye injuries following head injuries. So signs and symptoms of a possible head injury. Like I said, one pupil larger than the other, anoscoria, right? But anoscoria, once again, is induced. That's normal. That person's had it for a while, okay? Versus a head injury, you're gonna look and you're gonna ask, are their pupils normal? And they're gonna say, yeah, why is it not? And then one's gonna be really big and the other one's gonna be reactive to light and that one won't be. Now, if the eyes are moving in opposite, they're not moving in conjunction, that can be an indicator of head injury. If they can't follow your finger, indicator. If we have bleeding under the conjunctiva, so they're bleeding under their eyelid, right? That could be a pressure buildup. They have pressure from inside their head pushing blood out through the base of that conjunctiva. And then protrusion or bulging of one eye, that is not a normal thing. That's a head pressure buildup thing, which we'll talk more about intracranial pressure in the next lecture today, okay?
Sometimes you wake up in the morning and like you just got like bloody eye. Not a bloody eye, but like your white part is just like all red. Like you burst some blood vessel or something.
I mean, it's possible. I wouldn't attribute that to head pressure, like as a different, I would say maybe a pressure, like if you bear down.
Would you just like wake up with it sometimes?
I mean, I don't,
Happened to me a couple times.
I've never had that happen to me. I wish I could level with you. I have no leveling. Yeah, dude, I don't know. Maybe you should do a sleep study. Just make sure. Well, I know like some people don't close their eyes all the way when they sleep either, so they just dry out and get red, but that's not a blown vessel. That's a different thing. I've seen like a blown vessel from like people holding sneezes and that pressure in their face will cause a back pressure. I've seen something like that before, but I couldn't tell you why when you're sleeping. Good questions.
I know what you're talking about. I get it when the pollen changes really quick. It's just like super red in one spot.
So, moving on. Blast injuries. So signs, symptoms are gonna range from severe pain to loss of vision, okay? With obviously the potential foreign bodies. So if there's an explosion, things flying at you, okay? If there's a foreign body in the globe, we don't remove it. What do we do if there's something in one eye? What do we do to both? Cover both, very good. And then if only one eye is injured, follow your local protocol. If there's severe swelling. Now, if their eyelid is swelling shut, we are not gonna force their eyelid open, okay? We're just gonna leave that be. That's outside our pay grade. We're gonna leave that to doctors, okay? Now, contact lenses and artificial eyes. So for contact lenses, we do not attempt removal of contacts unless there are chemical burns to the eye, okay? Contact lenses stay pretty well in their place, okay? Now there's a couple of different types. There's hard contact lenses and there's soft lenses. The majority of the population wears soft lenses. There are small populations who prefer the hard lens or like following surgical procedures, they'll wear a hard glass lens just to keep the eye safe, okay? Now to remove soft contacts, you're gonna put some saline in there. You're gonna reach in, thumb and forefinger, and you're just gonna lift, pinch and lift, okay? Downside of a hard contact is they need a suction cup to get that out. Now here's the kicker. I've been in an ambulance once or twice. I have not one time ever seen a little suction cup for contact lenses. So what you're hoping for is if that person wears them, they have the proper apparatus to remove it. Not myself, but Chris had a call with a patient who had like these fancy like Norwegian glass lenses and he had something in his eye and he got really upset with Chris that they didn't carry the thing to remove his fancy Norwegian hard glass contacts. It's like, well, don't know what to tell you, man. If you're gonna choose to wear that, you're gonna need to have the device with you, okay? Not a common thing. So,
Can you ask them to do it for you if they feel comfortable doing it? Like,
Taking the lens out? Oh yeah, if they feel like they can. A lot of times people will panic though when their eyes are involved, which I have a story on that I'll tell in a second. But so A there is gonna be the hard contact lens, right? So they have the little suction cup. And then B, they put some of the saline in there, or we do, and then it's just pull out. And if the patient is more comfortable doing it, which most people I'd assume would be, if they're capable, have them do that. Does anyone wear contacts in here? Have you guys ever put the wrong saline solution in your contacts before? So there's two types of cases. There's the typical one that lies flat and there's a left and right eye. There's another one, and that's just saline. There's another one that's a standing case that uses a hydrogen peroxide solution to clean them. I don't know how long you guys have been in town, but it was the day of the Basque. We had the Basque soccer team and the Mexican soccer team come and play together. Here in Boise, it was a really cool event. That same morning, I used the wrong contact solution. So I had hydrogen peroxide in a flat case, put one eyeball in, and I immediately started screaming and panicking and went blind. Anyone in my range could have caught these hands at that moment. And unfortunately, it was my mom. I didn't hit her, but I was like, I don't care what you have to say to me, right? I'm blind, right? And my eye hurt for the rest of the day. So keep that in mind. That is something you may see from time to time. It happens.
Did it bubble? Like, was your eye like?
All I remember was I put it in, it was like, something's wrong. And you know when something's in your eye, that like pressure sound you hear? That was there for like the next 3 hours. It was horrific. Okay, let's take a 10-minute break. All right, let's get back into it. So we just talked all about the eyeballs and how terrifying and disgusting they can be. Let's move into the nose, okay? So nosebleeds, and the fancy term we like to use in medicine, epistaxis, okay? Epistaxis, very common problem. You will be dispatched to this a lot. Now, one of the most common causes, digital trauma. Can someone tell me what digital trauma means? It's not getting hit with an alarm clock. The old finger, no. You stare at the computer long enough, your nose starts to bleed. You're doing computers wrong. But yeah, it's usually your fingers, right? Or that's, I don't want to say usually, but digital trauma, they're talking about people shoving their finger way too deep, looking for gold, missing, hitting everything else. So, anterior nosebleeds. So nosebleeds that fall forward originate from the area of the septum and bleed slowly. So the septum is the deviating line. And that's just medicine in general, or anatomy in general. If we say there's a septum present, there's a deviating line down the middle of it. So for example, our heart has a septum. If we look through the middle pictures here, right, there's that big muscly divider. This is a septum of the heart, okay? Now, posterior nosebleeds, usually more severe, often cause blood to drain down to throat. So the ones that fall forward naturally, typically are going to be septal. The ones in the back, they tend to be more, they say more severe, there's just more vasculature. So it's not uncommon to get a bloody nose that goes back. Now, things to remember about blood. Blood is an irritant. Blood is not supposed to be anywhere but our vasculature. Has anyone ever had a nosebleed that they didn't feel like standing up and then they just let it go in their stomach? Did you guys throw up? Well, you guys didn't drink enough of your own blood, cowards. I vomited everywhere when I did that. And it's because blood is an irritant to your stomach. It's not supposed to be in there, so it makes you feel sick, okay? Yeah, also don't do that. And then pro tip, this is, in my experience, this worked for me. I don't know if this is the most medically accurate, but I used to get bloody noses a lot as a kid when it was drying out. So if you pinch your nose starts bleeding, pinch it for about 2 to 5 minutes, let it, and close it shut. And then after that 5 minutes, if you're not bleeding anymore, blow your nose. At that point, that'll make a big clot, and then when you blow your nose, you'll clear the majority of it, and the little clot will keep the rest of it closed. And if that doesn't work, rinse and repeat. But it does help. I used to do that a lot. Huh? It's counterintuitive for sure, but it works. It works, I promise. The body as a whole is counterintuitive. We learned that in shock, huh? It tries to kill itself by fixing itself. Okay, moving on from epistaxis. So, blunt injuries to the nose may be associated with fractures and soft tissue injuries, face, head injuries, right? Or injured C-spine. Remember, blunt trauma is not just blunt trauma. They got punched in the nose, they didn't just get punched in the nose, okay? Now, we'll talk about blunt trauma. Did I talk about the metal bar? Does that sound familiar? Yeah, I got hit in the face with it. Sound familiar to anyone? Okay. Blunt trauma can be pretty severe, right? Obviously, there's lines to it. Getting punched in the face versus getting hit in the face with a baseball bat are very different conversations. That's where we got to register the mechanism. Okay, is the mechanism deeper than what I'm seeing? Which more than likely, yes. Okay. Now, assess the nose structures for injury. So like I said, in the middle, our dividing line of our left and right nostril is the septum. Now, inside the nose, we have these things called turbinates. We have an inferior, medial, or middle, and then superior turbinate. And we have that on either side. So we have two sets of those turbinates. Those have a very important job. Remember the concept I said surface area is really important with our body? This is it. This is one of them. Okay, so when you take a breath, right? I think I might have mentioned this. When you take a breath and you get that cold air and you're like, oh, that hurts to breathe, right? In the wintertime, your turbinates help to, one, filter the air, but they warm and humidify the air we breathe. By breathing in through your nose, we're forcing this air to go through several different channels. By making it go through different channels, it's touching more of our tissue. Well, our body is warm, 98.6 to be around that accuracy, right? That's how we warm up the air we breathe, is that we make it touch more of our structures to warm it up so that when we take a breath and it hits our lungs, it's not jarring, it's not throwing us off, okay? Now, patients with severe nasal injuries may also have C-spine injuries, okay? Once again, just remember, read the mechanism. Now, cerebrospinal fluid, CSF, hint, hint, wink, wink, may be important. May escape down through the nose following a fracture at the base of the skull. Okay, control bleeding by applying a sterile dressing. How many of you guys have read the bleeding chapter? How many of you guys remember the halo? Does anyone know what I'm talking about with the halo? From the ears, we can also check on the nose. So the halo test. If we have, someone hits their head hard enough, and we'll talk about it again in head injuries. Someone hits their head hard enough, you're gonna take a piece of gauze, and if they have bleeding from their ears, bleeding from their nose, and you're gonna hold that gauze underneath there. Once you've held it for a couple seconds, you're gonna take that away. If there's a red dot in the middle and then a kind of yellow ring around that, that yellow ring is cerebrospinal fluid. Cerebrospinal fluid is basically the buffer that stops our brain from slamming into our skull all the time. So, in layman's terms, that's bad, okay? The inside fluids of their head that support their brain are now leaking out their nose, out their ears, usually indicating skull fracture, okay? Now, the ear, like I already said, we're gonna talk a little bit deeper about it. So, external, middle, and inner ear, different structures. So for the outer ear, the pinna and the tragus are gonna be the exterior portions, okay? They're gonna go in through that hole, that's gonna be our auditory canal, and it's the outer ear ends at the tympanic membrane. What's another name for the tympanic membrane? Your eardrum, right. Which people rupture it all the time, very commonly with one little thing in their bathroom. Anyone know what I'm talking about? Q-tips. Yeah, people shoving them way too deep, blowing their eardrums out. Oh yeah, and they'll bleed and you can't hear. Yeah, it's a whole thing. I've never had it, but I've seen it. Huh? You won't lose it'll heal. If you do it enough times, it's gonna start to scar over though, and then it's thicker, so your hearing will be disabled at that point, or...
It won't heal itself, right?
No, not typically. Has to be set up. Now, going into the middle ear, we have the three smallest bones in the human body. There's your trivia question answer. We have the hammer, anvil, and stirrup. Okay, those are the nicknames. It's the Inca, the stapes, and the malleus. Thank you. Yeah, three smallest bones. Now, this is how we actually hear. So remember, sound is vibration, right? Sound are waves of vibration moving through the air. So when that moves through our ear canal, bounces off our tympanic membrane, which is attached to the hammer there, it's gonna vibrate the hammer. Well, the hammer vibrates into the anvil, which vibrates into the stirrup, which then our brain will take that information, those vibrations, and convert it to sound we hear. That's also why those new bone conducting headphones work. Has anyone tried those out or used those? They're pretty cool. They go on either side of your ear, so you can listen to the music that you want to listen to or whatever, and you can still hear through your ear canal, but all they do is vibrate those bones so you hear the sound. Chris is a big advocate of them. He rides, he does like cross-state motorcycle trips, and he's told me that with those on, with his, the face thing that he wears to keep his head warm, and then his helmet, he can listen to a podcast riding his motorcycle down the freeway going about 70 miles an hour, clearly. They work really, really well. I'm not being an advocate or selling them, but I'm saying I want a pair, so. Huh?
Vibration headphones.
Bone conducting. Yeah. Now, moving from the middle ear, we have the inner ear, which is the cochlea. Now, the cochlea is also going to be help with the vibration to transmit sound through our auditory nerves there. But the cochlea also has another important function. There's fluid in there. Okay. Now, that fluid helps with our balance. I'm sure everyone as a kid has done this. You spin in a circle long enough, you get dizzy, right? Well, what you're doing when you spin is that centrifugal force is pulling that fluid to the side of your ear, so that when you stop, it's now going back and forth until it can regulate back down to the bottom, and that's why you feel dizzy. So fun facts. Fun facts. So the ears are often injured, but they do not usually bleed very much. If it does bleed, controlled with pressure typically works very well.
Is that like vertigo then?
Vertigo is a different thing, but it's part of it. It plays a role. Now, ears are often injured, like blah, blah, blah. In case of an ear avulsion, so the ear got cut off, wrap the avulsed ear in moist sterile dressing, put it in a plastic bag, label it, I guess, right? So we don't accidentally eat it or whatever. And then take it to the hospital. They can surgically reattach that. For tympanic membrane ruptures, patients will report severe ear pain, difficulty hearing, or ringing in the affected ear. What's the med term for ringing in the ear? Tinnitus. Yeah, they'll have that tinnitus. Huh?
It's not fun.
It's not fun, no. If you're on an ambulance long enough, you'll have it always. It's fun then. No, it's not. Moving on. So tympanic membrane rupture may be caused by insertion of objects too far into the ear. Once again, typically Q-tips, but could be anything that gets too far into the ear, okay? With kids, they'll put a lot of things into their auditory canal. They'll put things in their ears. My sister used to put corn in her ears and up her nose when she was a baby. I don't know. Huh?
Kernels.
Like kernels of corn, yeah. Yeah, it answers a lot of questions we have about her now, but it's one of those things that you get used to. Kids do dumb things with that. Now, if we have that clear fluid coming from the ear, that can indicate skull fracture. What's that clear fluid again? Yes, cerebrospinal fluid, or CSF. Very good. For face fractures, now typically the result of blunt impact, okay? Assume a direct blow to the mouth or nose has caused a facial fracture. We obviously don't have x-ray. X-ray vision is still in the mail, haven't gotten the chance to use it yet, okay? If someone gets hit hard enough in the face, we're gonna assume they have something broken, okay? Now, other causes, bleeding in the mouth, inability to swallow, or excuse me, not causes, clues, bleeding in the mouth, inability to swallow, absent or loose teeth, and then loose or movable bone fragments. If we push and we can move things around, that's problematic, okay? And then just remember, unless they've got, there are demographics where teeth are a little bit looser. I'll say a lot of times it's drug related, but teeth are pretty anchored into our mouth. So if people are breaking teeth, they got hit hard, okay? Think about all the times you've been hit in the face, accident or on purpose, and you still have all your teeth, right? Think about now how hard it would take to break your teeth. So, facial fractures alone are not an acute emergency unless there's serious bleeding with that. Okay, so like a broken nose, not an acute problem, right? That's not a life threat. Sucks, but it's not a life threat. Now, plastic surgeons can repair damage to the face and mouth if they can treat it within 7 to 10 days. And then within that first 24 hours, swelling can be extreme, right? Like I was telling with my friend who got hit the baseball, his eye swelled up really, really big. He fractured his orbit. 24 hours later, it was giant, right? But surgeons can go in and repair that. Same with like broken noses. I broke my nose when I was 11, and I got mine fixed at day 14 because we didn't know I had to be in there sooner. They had to re-break my nose to get it back to normal, okay? So it happens. Dental injuries can be traumatic to the patient, right? Obviously, teeth are sharp too. Has anyone ever heard or seen teeth go through someone's lip? All right, I put my teeth through my lip when I was a kid, right? It happens. So teeth can be a cause of soft tissue damage, right, and trauma. But then also think about it from like an emotional standpoint for this person. People invest a lot of money and time and effort into their teeth. So if they bust all their teeth, expect them to be pretty upset, okay? Now, bleeding will occur whenever a tooth is violently displaced from its socket. Okay, so how we're going to stop that bleeding? Direct pressure. Now, here's where I will also advocate Maybe we have the patient hold pressure. That way you're not holding your finger in somebody's mouth just because mouths are kind of nasty and who knows if they feel like biting, okay? Suction as needed. And then if we have cracked or loose teeth, those are possible airway obstructions, okay? Remember that. Anything floating in the mouth or throat is a potential choking hazard or aspiration risk. Aspiration means to breathe in something, not air. So blood, vomit, sputum, spit, okay? Now, if we have an avulsed tooth, I'm just checking something. If we have an avulsed tooth, save and transport the avulsed tooth. An avulsed tooth, remember, is coming out. If it's been forcibly removed and we have the whole tooth, I'm sure you guys can imagine a tooth, right? There's the tooth part and then there's the two prongs on the bottom. The prongs are the roots, okay? So when we handle a tooth that's been avulsed, try not to grab the roots because those are going to be what go back in and we don't want to have to re-sterilize. They're going to be cleaned again, but we don't want to just increase the risk of potential infection. But for us, we're going to put it in a storage solution, cold milk or saline. Now, reality, we don't carry cold milk. Feels like kind of a nasty risk. So you're going to be putting it in saline unless you're at like somebody's house and they happen to have milk. You can try and use that. Make sure you let the hospital know as well that you're bringing in teeth because they can actually re-implant those teeth as long as we're there within 20 minutes to an hour, okay? They can replace the teeth. Sorry, I'm trying to remember where everything ended. Yeah, Carter.
If you don't have any of that, I've heard if you just put it in their cheek, put it in near their lip, does that do the same thing?
So if we were to put the tooth inside their mouth and their cheek instead of
If they
that.
don't have airway problems or anything.
Yeah, I would still venture to not do it because we're still risking an airway, right? We're still putting something in their mouth that could choke on. You're always going to have saline. So use the saline. Yeah.
It's more like survival situation.
Yeah, like if you're out in the middle of the boonies, that's a different conversation. It's the same thing as like I've heard if you have a contact out, put the contact in your mouth until you can get saline. I've done that before. It feels gross. Well, I'll be honest with you. Total transparency is nasty, but you gotta do what you gotta do in survival. That's a different conversation though. Okay, if somebody's got something impaled in their cheek going through their mouth, okay, first of all, what did I say about impaled objects? Do we ever pull those out? Not really. There's two caveats, right? CPR, it obstructs CPR, it obstructs the airway. Well, if someone's got a knife going through their cheeks, did you say that's an airway obstruction? That might be an indication to pull it, okay? Now, if we're unable to control bleeding, consider removal. Put direct pressure on the inside and outside. That's one where if the patient's conscious, maybe we have them do that, okay? If they're unconscious, be just really cognizant of where your fingers are as you're holding that pressure. And then remember, the amount of bandaging should not include the mouth. We don't bandage people's mouths closed. That's a problem, okay? For injuries to the neck, so remember we got some big structures in our upper airway. Blunt trauma can do some pretty severe damage. Our trachea is pretty pliable, but you can still break it, okay? So our esophagus, with blunt trauma, all of these can be affected. The esophagus, carotid arteries, jugular veins. You can have damage to the thyroid cartilage, cricoid cartilage, or even upper parts of the trachea itself. Like I said, can damage that. So any crushing injury of the upper part of the neck, likely to involve the larynx or trachea. That's one where you should definitely call ALS because we're going to need to get creative with an airway. You guys are not going to be able to deal with that depending on the severity. Now, can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction. Okay, and then the leakage of air into soft tissues of the neck. What's that called? Leaking air into the soft tissue of the neck. Gives a Rice Krispie-like sensation. Well, say it loud and proud. Subcutaneous emphysema. Yeah, very good. Very good. Yeah, so subcutaneous emphysema, characterized by crackling sensation produced by the presence of air. I've only ever gotten the chance to feel this one time, and it was in the ICU, and this dude was inflated, like half of his side. It felt crazy. I don't know how else to describe it besides like, you know when you get a package and there's like that thin plastic layer that's not like foam, but it's like almost like a foam plastic? It kind of feels like you're pushing through a bunch of that before you touch their skin. It's gross. Now, you can have complete airway obstructions, and then obviously consider ALS, because like I said, we can get a little creative with those airways as need be. And then as always, if we're talking facial trauma, read the mechanism. Is there a reason to put a collar on? Let's protect that spine, C-spine. Question, yeah.
Almost similar to crepitus.
Yeah, so yeah, it'll be like a similar sensation to crepitus. Yeah, but it's not so much, crepitus is broken bone. You're gonna be pushing through like a crackly sensation until you touch their body because their skin's inflating off. I'll show you a picture when I'm done with this side. So, for penetrating injuries, can cause profuse bleeding, okay, especially if they're gonna be lacerating the great vessels in our neck, great vessels being carotid and jugulars, okay? So, injuries to the carotid and jugulars can cause that exsanguination. Okay, they can bleed out from their neck. Okay? Now, injuries to these large vessels may also allow air into our circulatory system, which can lead to an air embolism and cardiac arrest. Okay? But keep in mind, direct pressure will control most bleeding. If it's jugular vein bleeding, that pressure will work. Does pressure typically work with arteries? No. Well, this is the neck. Do we have any other options? Can we put anything else on the neck to stop that bleeding that's arterial?
Gauze.
Huh?
You could put gauze on there.
Yeah, but pressure, right? That's all we're gonna do is just pressure. No tourniquets, remember.
Do the like arm thingy.
Yeah, I can, yeah. If you remember the thing when I had him raise his arm, put it on the opposite side and pull natural pressure back against the neck. Yep, that's a good one, but it's not gonna, if it's arterial, it may not completely stop it. That's a race against time. So, moving forward, laryngeal injuries, right? The voice box. Blunt force trauma to the larynx can occur when unrestrained drivers strike their steering wheel, and then snowmobile riders strike a clothesline. That's like a very specific example. I hadn't heard of examples of that personally. I've seen a video, I'm sure some of you, if you ride dirt bikes out in the wild, you've seen it before. There was a while where people, instead of marking their private land, they were stringing barbed wire across trails, and so people were riding into them. One guy I saw the video, fortunate, hit him in the chest plate. And then I was talking to a student who lived in rural Oregon, and they said that they actually had a friend who got decapitated for that same thing, riding a snowmobile. Someone strung barbed wire, riding fast through it, clean off. So if you're gonna work more rural areas, you might see this. If you're gonna work somewhere, like especially in this area near the foothills, maybe, okay, just not a high likelihood. Now, the larynx becomes crushed against the C-spine, resulting in soft tissue injury, fractures, and or separation of fascia, right? So fascia is the connective tissue that holds our skin to our muscles, so you can actually start separating the skin from the muscles themselves, okay? Penetrating or impaled objects. So once again, talking about it, should not be removed unless it interferes with CPR or obstructs the airway, which I would even argue is interfering with CPR. Right? Because we gotta breathe for that person. We gotta bag. So if we can't bag, we gotta pull it. Okay. Outside of that, if they're just in there, they're not obstructing, stabilize in place. Yeah.
Probably another answer to this, but would we ever remove like piercing or what's it called,
like the dermal. Yeah. Would we ever remove piercings? I want to say not likely, unless there's for some reason like they have like a dangling chain or something between the two that's really just getting in the way. Yeah. But for the most part, not really. And if in that example I'm thinking of like if they had a chain dangling for whatever reason, I'm more apt just to cut it in the middle than I am to remove the piercing. Because if we remove it, then we're we're potentially introducing bacteria, some sort of infection agent.
Okay, that's what I was saying. I was thinking more like the tongue, like I don't know. Like,
yeah.
There would never is blocking that airway.
Yeah.
You don't really want to put your hands in the mouth anyways.
Right. The safe answer is going to be leaning towards no, unless for whatever reason that is the reason you can't do it. Yeah. And at that point, you got to make some choices. Okay. Maybe a medical, oh man, that might be a medical control one also. Yeah, worst case. Good question. All right. So signs and symptoms of larynx injuries: respiratory distress, right? If your throat's closed, it's hard to breathe. Hoarseness, so they're having a hard time talking. Pain, difficulty swallowing, dysphagia with a G, it's showing up, dysphagia, versus dysphagia, which is difficulty speaking, but it's got the S instead of the G. Cyanosis, pale skin, or sputum in the wound. When I show you guys the Airway video, or that Crike video, it's got a great example of what sputum is. You'll see exactly what I mean. It's a very frothy spit, okay? Okay, we're there. So Other signs, symptoms, subcutaneous emphysema, bruising in the neck, hematomas, bleeding. And then as far as management of these injuries go, oxygenate. We can ventilate if we need to, okay? And then always, remember, if it's a larynx, that's the front of the throat. C-spine's probably affected also. Let's get a collar on them, okay? One more thing I forgot to mention. What do you think our eyes are gonna do? Say I'm reading a book, and I'm talking about pupillary constriction or dilation. I'm reading a book, and I'm getting close to it. What do you think my pupils are gonna do? They're gonna constrict. Do we need a bunch of light to read that white page? No, it's gonna constrict, okay?